Okay, we did adeno and squamous and bronchiolo-alveolar, which is a subtype of adeno, by the way, in the classification scheme, but it is a unique subtype. Small cell carcinoma is our last major type, and here we have the trachea and main stem bronchi, and we see a large infiltrative tumor mass that's arising from the bronchial mucosa right here and infiltrating into the hilar lymph nodes. Those are these little lymph nodes right around the hilum of the lung here, and this is probably the origin of the tumor. Morphologically, it's just as you would expect. The cells are small. What do we mean by small? Less than 25 micron nuclei in small cell, as opposed to usually 30 to 50 or more micron in large cell carcinoma. Little cytoplasm, dark hyperchromatic, but pleomorphic nuclei. That is, some are round, some are oval, some are spindle, funny looking shapes, but they're all small and dark. On a fine needle aspiration specimen, you can see these small pleomorphic cells with dark heterochromatin and inconspicuous nucleoli, diagnostic for small cell. This is a smokers only cancer, the most aggressive biologic behavior, always assumed to have metastasized widely at the time of diagnosis. So because of that, because there is evidence that that does occur early, the small cell carcinoma is considered a systemic disease, even though the primary tumor mass may not be that large. So chemotherapy is the cornerstone because you can't cut out systemic disease. Peripheral small lesions with node negative and metastasis negative are very uncommon, and we can surgically resect those. Okay, so surgery is indicated to remove small ones, but one would still use chemotherapy as an adjunctive therapy, even if surgical treatment is used. Now, the large cell carcinoma is the wastebasket category of the large cell tumors. So we have adenocarcinoma, that's a large cell carcinoma, a non-small cell or a large cell. We have squamous, which is a large cell carcinoma, and we have this poorly differentiated large cell carcinoma, which doesn't look squamous and doesn't look adeno, so it's the wastebasket. We put tumors in this category if by light microscopy we can't classify them into the other groups, but it does include, when one studies them with immunohistochemistry or electron microscopy, now we use immunohistochemistry, 3 lines of differentiation. These poorly differentiated large cells can either be a poorly differentiated adeno, in which glandular features are present at ultrastructural level, a poorly differentiated squamous carcinoma with squamoid features by electron microscopy, or a large cell neuroendocrine carcinoma arising from neuroendocrine cells. And we recognize that either by EM, showing these neurosecretory dense core membrane-bound granules. All of these are neurosecretory granules. Here's the nucleus over here and the cytoplasm. We can do that by EM, but much quicker and easier to do now is immunohistochemistry for CD56, which is a adhesion molecule, synaptophysin, which is a synaptic vesicle protein, or chromogranin A. So most pathology labs would take this easy way out and do probably two or all 3 of these markers to diagnose a large cell neuroendocrine. We are particularly interested in making this diagnosis because we need to accumulate data that shows whether this subtype of large cell, this one, has a different prognosis and possibly could be treated differently. So these researchers are catching on to the dolphin's language. Other lung tumors. In the other category, we have neuroendocrine neoplasms. They come from the neuroendocrine bronchial epithelial cells, but they are showing a range of biologic behavior much less aggressive than the small cell carcinoma. We have them showing a range from obviously benign to some uncertainty about their malignant potential to frankly malignant ones, which are the small cell carcinomas. So we're mainly going to talk now about the benign versus the uncertain potential. Neuroendocrine cells are in all these places. Virtually every organ of the body has neuroendocrine cells. Here they are in the fetal lung, as detected by an immunohistochemical stain for chromogranin A. So they're there very early in fetal development. And here's the adult bronchus with the positively stained neuroendocrine cells. So if you have a very well-demarcated submucosal nodule protruding into the lumen of the bronchus, and it looks humdrum, all uniform cells, round to oval nuclei, everyone looks like each other, very low mitotic activity, lots of abundant granular cytoplasm. This is called a typical carcinoid, the lowest histologic grade, the best differentiation, and probably benign behavior. Then we have a bigger tumor that is filling the lumen of this bronchus, so it has grown out of this bronchus and now fills the lumen. And here we see more nuclear pleomorphism, small, medium, large, larger nuclei, and frank necrosis of tumor cells. We now would call this an atypical carcinoid, one step more aggressive than the frankly benign tumor. So pathologists have devised a classification that recognizes two neuroendocrine tumors that are not as aggressive as small cell carcinoma. And these are called carcinoid tumors, no necrosis, low mitotic rate, uniform cells, very high survival. Why not 100%? Because some of these, despite these histologic features, may develop metastatic behavior. So this is a spectrum. The atypical ones with moderate differentiation, pleomorphism, focal necrosis, higher mitotic count, sort of a mixed bag of decent 5-year but lower at 10 years, so a slow growing but definitely significant metastatic potential. And just to drill the point home, these are the better differentiated neuroendocrine tumors, but small cell carcinoma and large cell neuroendocrine are more aggressive than these two, so we don't call these carcinoids, we call them small cell and large cell. They are aggressive and have much lower 5 and 10-year survivals. Here are pulmonary mass lesions that have to be differentiated from lung cancer. So this one, a hamartoma, is a mass, this is a definition for hamartoma in any organ, a mass of abnormally arranged but histologically normal tissues in an organ. It's a solitary mass, it's asymptomatic almost always unless it happens to grow into a bronchus and cause cough or hemoptysis. Slow growing, surgical cure, no malignant transformation. So here's this lobulated, well circumscribed mass, and under the microscope it has hyaline cartilage, it has respiratory epithelium, it has fibrosis. Everything is histologically normal. It's just in a very strange mixture, a hodgepodge of normal elements. Now, the inflammatory myofibroblastic tumor is a little different. Still well demarcated, but this usually develops in the setting of chronic inflammation, peak incidence in early years, and in these lesions you have a very high cellularity composed of inflammatory cells and mesenchymal cells, spindle cells, and this spindly cell myxomatous stroma. So on first blush, this tumor looks like a carcinoma. But one has to be aware that in carcinomas, first of all, you don't normally get a lot of proliferating fibrous tissue. It's usually more reactive collagenous fibrous, and the cells are much more pleomorphic than the proliferating mesenchymal cells in this lesion. So kind of a fake out for cancer, inflammatory pseudotumor. Pulmonary lesions composed of lymphoid cells. There's a spectrum here. So let's do the spectrum. Thanks to Dr. Pashevsky for this table. Lymphoid interstitial pneumonia is a non-neoplastic lesion. These are polyclonal lymphocytes infiltrating the septi. You treat them with immunosuppressive lesions and may get a decent response to those. So that's a non-neoplastic infiltrate. Nodular lymphoid hyperplasia are nodules of hyperplastic T's or B's or dendritics, single or multiple nodules cured by excision, not neoplastic. These last two are neoplastic. We have low-grade BALT lymphoma, bronchial-associated lymphoid tissues. Just to preview the GI course, there's also low-grade MALT, which is mucosa-associated lymphoid tissues. But here they are in the lung. Sheets of monotonous cells infiltrating around bronchovascular bundles. Half of these are asymptomatic, most are localized, but 20% of them will be bilateral. Pretty good 5-year survival with combination of steroids and chemotherapy. So indolent, but a potential for causing death of the patient, generally indolent. And then we have our high-grade lymphomas that are B-cell type, big masses, but unfortunately asymptomatic, and they have about a 50% 5-year survival, treated with multi-agent chemotherapy, just like a lymphoma involving lymph nodes. Staging issues. For small cell cancer, it's simpler. A simple stage system can be used because surgery or radiation therapy are of potential benefit only for very small tumors of low stage. So the treatment options in small cell are almost always chemotherapy, except one may add surgery or radiation for very small ones. So in limited stage and extensive stage are the only two categories. Limited stage, about a third of cases, one lung and lymph nodes on the same side of the mediastinum as the lung that's involved. So those are, lymph nodes are involved. The tumor involves an area small enough to target with radiation therapy, so it's not diffuse. That's the categories or the requirements. Most cases, up to 3/4, are extensive stage, involving both lungs or contralateral nodes or widely distant metastases or a malignant pleural effusion. All of those make extensive stage. Now, non-small cell lung cancer is a problem not in actual completing the staging, but in actually being careful about how you do it, because it's much more complex. These next few slides are not for you to memorize. I want to present the process of staging a lung cancer based on T for tumor size and location, N for lymph nodes involved, and M for distant metastasis, which means beyond the regional lymph nodes. I want to show you how this TNM system, which is used for cancers in virtually all organs, is applied to the biggest killer in the United States. And we actually end up, by doing this staging system, with 7 groups that have prognostic significance. That's why we use this classification for staging. So here are the general principles. We can consider surgical resection, and it is usually done for all stage 1 and 2, and some stage 3, particularly the 3As, with intent to cure. So surgery does cure durable remission patients with lower stage non-small cell lung cancer. Chemotherapy is used for everybody except stage 1, treating metastatic disease whether you see it or whether you don't. And radiotherapy is used for local treatment of tumors that cannot be resected, which is stage 3B and 4. These are getting surgery plus chemo, except stage 1. 3 and 4 are getting radiation plus chemo. So when we do the T codes, this, by the way, is from the same NIH cancer.gov sites for non-small cell lung. By the way, they have health professional tabs and patient tabs. Click on the health professional tabs and you'll get more than you want to know. These are the T categories. So this is tumor size and location. These are the N categories: no nodes, ipsilateral nodes, ipsilateral mediastinum, and contralateral. And metastasis: none, yes, either it's in the contralateral lung or a pleural pericardial effusion, or it's outside the thorax, 1A, 1B. So again, not to memorize these, but just to show you the careful descriptions of primary tumor nodes and mets result in, so if you do all the classification, you do the T work on your pathologic specimen, you do the N work on the pathologic specimen or the scans, you usually do the M work by imaging studies, you get all these combinations and you end up with carcinoma in situ, 1A, 1B, 2A, 2B, 3A, 3B, and 4. And now these categories, these staging ranges, note that there are 7 of them after CIS, do have prognostic significance. This is from the AJCC staging manual, and these numbers here are from an article by Strickler and Crawford in Scientific American Medicine. So 1A, 73%, 1B, 58%, 2A, 2B, a little worse, 3A, a lot worse, 3B, really bad, and 4, really, really, really bad. So note that these are the surgical ones, between 36 and 73% 5-year survival, and this can be a surgical one, but often still has a bad prognosis. Now I'm sorry, that was one page. And why do I have this on here? I think this is a double slide. Yes, it has to be. So Dr. Colas was confused when he put in 2 slides that are the same. How about bronchiolo-alveolar versus non-small cell? So bronchiolo-alveolar 5-year survivals, remember this is a subtype of adeno, so stage 1 through 4, better than all the non-small cell 5-year survival. At every stage, we're better if you have a bronchiolo-alveolar carcinoma. So that's just to show you that if you had one lung cancer, you would like it to be bronchiolo-alveolar subtype. The clinical presentations we'll come back to in a moment. It's time to break.